parameters for prediction of LV morphologic and functional remodeling in chronic ischemic patients, the Doppler SIP trial. Dr. Douche?
Yes, thank you. Good morning, everyone. It's a pleasure to be able to show the results of the Doppler CIP study on behalf of the whole consortium. This study was actually funded by the European Union within the 7th program framework. These are my declarations of interest. Cardiac morphologic remodeling is a process where a normal heart over time evolves towards an enlarged heart that can result into bad function, ultimately into heart failure and death. The whole process of this is not completely understood, but important triggers for this remodeling are thought to be ischemia, infarction, and changed loading conditions, amongst others. There is a general consensus, however, that this process is irreversible. So once the heart has become enlarged, it cannot return to a normal-sized heart. So in that sense, as this remodeling process could be seen as a first step towards heart failure, early detection of this remodeling process is critically important so that treatment can start early. Is it affecting many people? Well, as I said, two important triggers could be ischemia, infarction, and as you will probably know, coronary heart disease affects 2 million, or causes 2 million deaths per year in Europe currently. So that's about 25% of all deaths. If we then take into account that there is better treatment of the primary diseases, it implies that the incidence of heart failure is only going to increase, which is amplified by the aging population. So actually this remodeling phenomenon is something that many people one day may face with. Now, how can we detect remodeling? There is multiple imaging modalities, ultrasound, magnetic resonance imaging, SPECT. I did not list CT here, which is of course an important modality, but it's not clinically used currently to merely look at the anatomy and function of the heart. So we did not use that modality in our study. But each of these modalities actually produces all kinds of images, looking at anatomy, looking at perfusion, looking at function, looking at inflow patterns, and so on. And each of these images can create a number of parameters that try to characterize the state of the heart, and that could therefore be predictive of this remodeling process. So of course the natural question then arises, which of these modalities and which of these parameters is actually more accurate in, or prognostic in predicting future morphological remodeling? And this was the goal of the Doppler SIP trial. The trial started in 2009 and patient recruitment started January 2010. And over a period of 3 years, 676 patients were recruited with stable coronary heart disease in 6 centers across Europe. In all of these patients, we tried to do as many imaging exams as logistically possible, among which ultrasound, SPECT, and MRI. Blood samples were taken, clinical data was collected, these patients went through exercise testing, and they filled out a quality of life questionnaire. 2 years later, we did a follow-up in as many patients as possible. We had a dropout rate of 8%. Again, we collected quality of life data, clinical data, and we did imaging to determine remodeling. Importantly, all the data was analyzed in a blinded manner, anonymized manner by core labs. So there could, in that sense, not be any bias in the study. What did we find? Which set of parameters seemed to be most prognostic for future cardiac remodeling? It was the group of parameters that actually tried to say something about left ventricular morphology. And if we zoomed into this group of parameters, which parameter specifically, it turned out to be the end-diastolic volume. So the absolute size of the left heart seems to be most prognostic to future remodeling. And in particularly, if we looked at the different modalities, it showed to be MR that was the most prognostic. How actually did end-diastolic volume or ventricular size predict remodeling? A bit surprisingly, it were actually the smaller hearts, the smaller ventricles with low end-diastolic volumes that had a higher likelihood of remodeling. On top of that, as a secondary effect, the hearts with the larger left ventricular mass, so the thicker walls, also showed an increased likelihood of remodeling. This goes a bit against common belief that, or a generally accepted hypothesis, that it is increased wall stress that would be a trigger for left ventricular remodeling, because actually these data show that it's the ventricles with the lower wall stress that would be more prone to remodel. So we concluded from this study that in this group of stable CAD patients, morphologic remodeling is best predicted by morphological characteristics of the left ventricle, in particular anti-systolic volume. That anti-systolic volume measured by MRI was most prognostic. We'll have to see in a cost-benefit analysis, which will be done in the following weeks, whether this still holds if we bring the cost of the exam into account, because anti-systolic volume can be measured by the other modalities as well. From a pathophysiological point of view, we actually observed that remodeling is occurring frequently in this group of patients, that it surprisingly occurred most likely in normally sized ventricles. And this goes well against the well-established hypothesis that the cause of remodeling is increased wall stress. Thank you.
Thank you, Dr. Tahouj. This is open for discussion, questions. Yes, sir. Front row. This microphone coming.
Bruce Jansen, Cardiology News. What are your thoughts about this counterintuitive finding?
So, sorry?
What are your thoughts about this unexpected finding?
Well, we started generating, of course, new hypotheses of why this would be opposite of what we thought so far. So far, we have to be very careful on what we say, but it could actually be that a low wall stress situation is also not beneficial, and that for good function, you need some wall tension for proper contraction to be developed. But that remains very speculative and needs to be further investigated.
Second row on the left.
Marlene Besco from theheart.org. Would there be any clinical implications from this finding?
Well, actually, I'm a scientist, and so I asked one of the collaborators, clinicians, to back me up if there were more clinically oriented questions. So I'll pass on that question to Professor Engvall from Linköping University.
Microphone. Great.
In this case, we haven't studied any therapeutic ways of accessing this, but I think we have a knowledge that the big heart failure population is the people with diastolic dysfunction and thick ventricles.
Okay. Any other questions? If not, thank you, Dr. Tahouj.